Why would you not communicate with the patient's dental office to let him know? Was there communication with the patient's family physician so that they know? So this is where we can really start to close some loops.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists, episode number 153. My name is Andrew.
And this is Michelle. How are you? Welcome back. Happy to have you.
Are you talking to me or are you talking to listeners? Which
listeners?
Who are you happy for at this point? Oh my gosh. Can I just quickly tell you this week, it's just different. I've been really focusing on Airway. As you've said, and every time I've ever talked to you about Airway, once you see it, you can't unsee it. Okay, that whole thing. So I'm talking to my patients. You would be surprised, I think, about how many people are aware that they have airway issues and don't think it's a big deal.
Really? Tell me more about that.
So I may or may not have had a patient. I can't remember if I'm allowed to say that because of HIPAA reasons. And I may or may not have been talking to he, she, or them, or they, whatever is a non-descriptor so that you don't know who it is. But I was talking to the patient and I said, because I'm seeing these signs. The scallop tongue. I'm seeing a lot of attrition in the anteriors, and I'm like, I've been really just listening to a lot of these podcasts lately about, which is, I know our podcast, which is really weird, but like I've been listening to these amazing podcasts, like the best ever, and I think there might be something also causing all of this other stuff that might not be anything anyone's going to talk to you about. Have you thought about maybe, do you have any airway issues? Are you a heavy snorer? Are you this and that? And this one particular patient said that their significant other, so they got an app on their phone to see, like the snoring or whatever it was, not probably the way that Cyndee or Julia would have you get tested for airway issues, but
it's
just
a good
to see,
start, right?
It's a free app you put on your phone to see if you're snoring. And they said, well, it's not me, but it's my significant other, and they are snoring, and every time they snore really loud is when they wake me up. Yeah. And I'm like, so not only is the person's airway, them are probably also mildly affected, but like they aren't getting continuous sleep because someone else's airway in their same bed is now affected and problematic. So yeah, it's very fascinating how actually hyper aware a lot of people are.
Well, when you don't sleep well, you know about it, right? But it's just kind of like, how do you connect the dots? Which is what I was doing this past week, seeing patients. Again, we learned so much from Noelle that we are being very cautious with our PHI, our private health information for our patients. But there were 2 out of the 3 I saw one day screamed airway issues. Right. Like even one of them was so bad that I was like, could you go this week? Like, do you have a doctor? Like, how can I help you find somebody? Because again, I haven't yet found a referring cohort, I guess, to send these patients to. So I think where I'm at is probably where some hygienists are also going to be, in the fact that we are learning this stuff, and I can't exactly make a change just yet.
Well, yeah, and
just yet, in this moment.
Know exactly how you're feeling, because I feel like a lot of us are in that same boat. I think the beauty of this particular episode, though, is going to be helping us kind of get over that hump, right? Like,
exactly.
You heard in episode 2 where Julia was really kind of leading that particular episode. Well, guess what? Now it's Cyndee. She knows so much about helping our hygienist transition now into what's the next step. After you know all of these things, then what? And so that's what we're going to be talking about today.
Because it's going to be something that we are going to have to make an effort to figure out how we can help these patients. I have been contacting people in my local area, asking my local Facebook forums, like, who is doing tongue tie release? Anybody do myofunctional therapy? Does anybody do sleep and airway assessment? Like, I'm asking because I can't learn this and see these people suffer anymore without me giving them options. It breaks my heart. So I think that's where a lot of us are going to be in the very beginning. And I think Julia and Cyndee really brought to us how we can have those conversations. And so I think you guys are really, really going to enjoy this episode.
Hey, Michelle.
Yeah.
It's time for the interview.
Oh, but I had something else to say.
We need to let the experts talk now.
Fine. So we are very excited for episode 3. If you've just dialing in, or if you've been following along to episode 1 and 2 with Airway, we are going to tackle, like, we've kind of built the foundation, and now how does this apply to you? How are you going to use this in the conversations that you would have? Is that kind of where we're going with this? Mm-hmm. Very excited. So welcome back.
Hi, guys.
Yeah, welcome back. Cyndee and Julia.
Oh, my goodness. So Julia and I really see the synergy between medicine and dentistry. And being that airway is one of these confusing subjects that people don't know if it's medical or if it's dental, and there's how do we bill? Is it medical billing or dental billing? Mm-hmm. And what do we say, and where do we send them, and how do we do it? How do we recognize it? And they just say, this is all too overwhelming, so we're going to stop.
Right.
And so what we've done is we've created a way to encompass this into your day-to-day assessments and recommendations, care that you deliver to the patients that come in to see you. And what's really interesting about this, well, there's so many things, but one of the things that really interests me most is when we see our patient, one of the first questions that we ask them is about their health history. Mm-hmm. And I've always found that to be so ironic, because we ask these questions, tell me about your health. And then we say, okay, and we document what we're legally obligated to document, and then we forget about the health, and we move to dentistry. And I think that's a great symbolism for why we're trying to do what we're trying to do. And so what I'm hoping that I can help today with is to provide a way for dental hygienists and dental teams to really understand some of the ways that they can drip information into their patients' ears that might open up their minds just a little bit to some of these important issues. Before I start, I want to talk a little bit about the beginner's mind. And I don't know if any of you are familiar with that concept or have heard anything on it. It's kind of a new TED Talk these days. But I heard this woman speak to the beginner's mind several months ago, and it had a huge impact on the way that we teach. And it goes something like this. Those of us who've had children or around children, or you can really apply it to anything that you do in life, think about the little child that you strap the water wings on, and they go to the edge of the pool, and you jump in and you say, okay, jump to uncle, or jump to brother, jump to mom. And they say, oh, I can't do it. And sometimes they say they won't, and then they're frustrated with themselves because they didn't try. And yet they do it for the first time, and they squeal, and they can't get to the steps quickly enough to do it again. Mm-hmm. And so that's really the fabric of what we hope to do when we're teaching teams how to implement something new. And I'm considered a dinosaur hygienist at this point in time, so I've seen a lot of things change in our profession. And Airway is one of the many things. But what we try to do is say, okay, today, Michelle in episode 1 said it's kind of a buzzword, and we've determined through those processes that it's not a buzzword. It's a huge health issue. So how do we take something new and shed guilt, shed ego, shed fear, all of those things that would prevent us from jumping over the edge of the pool with our water wings on, right? All of those things that our 2-year-old did. Why aren't we struggling with it, right? And people's lives are at stake. I mean, we were there to catch them, and it was still that scary. So that's what I want to do today, is just walk you through sort of how to implement, how to ask questions, and how to bring your patient into their own diagnosis in a very loving, compassionate, health-centered way. So that's what I'm going to do.
Excellent.
Yeah.
So where do we start with that?
Well, so the first thing that I want to talk about is calibrating ourselves to excellence versus calibrating ourselves to how our doctor might treat or how our doctor might not treat. And what does calibrating actually mean? So we're all in this profession, some of us licensed and obligated to those licenses. So what does that mean? And if we set a course for ourselves to calibrate to excellence, we don't have to worry about anything else. We know that we're providing the highest level care. We're delivering what our patients are there and what they need and deserve. So we developed, and what I want to share with you all is a series of assessments that helps to drip information comfortably to a patient. Is everyone familiar with a drip campaign and what that means in marketing? So,
but maybe it'd be good to define that for some. Some people that might not be familiar with that.
Sure. So maybe you get a flyer, or take it back a step further. You see a billboard on the freeway that says something amazing is coming.
A Tale of Two Hygienists podcast.
TOTH. What is that? TOTH is coming. Everybody's going, what on earth is TOTH?
Yeah.
We're really excited about it. Then maybe next week they get a postcard in their mailbox that says, Tale of Two Hygienists, the #1 podcast coming to Las Vegas. Will you be there? And then maybe 2 weeks before it happens. So you build the information in such a way that it captures their attention, and then they may want to act on it. And it's the same with delivering assessments and recommending treatment for patients. So with our drip system, we're taking into consideration everything that we possibly can to help guide our patient there. Health history, rather than talking about the medications and jotting them down into the computer, asking, are you taking any new medications? Has anything changed? And circling back to the ones that are there. Maybe we've said, okay, 6 months prior and 6 months prior to that, but let's talk about them today. Julia, you touched on some medications earlier with teenagers, with the elderly. How many of our patients are taking blood pressure medications? Maybe multiple. How many of our patients are taking AFib medications, heart medications, statins? All of these things that we now know are putting a Band-Aid on one of the symptoms of airway. I want to give you an example. I had a woman come in. She was in her mid-60s, and she updated her health history for me, and she was on a new AFib medication. And so I asked her if she knew why they had recommended that medication, and she said no. And her cardiologist didn't really know why either. Couldn't put a finger on why this was happening to her. And you know what's coming, I'm sure. We're into this 3 episodes now. So point being, if I had just written that down and gone about the daily tasks of seeing that patient for a hygiene visit, we would have missed an enormous piece. That woman has now had a sleep study. She's now using a CPAP, and she's feeling better. She's looking better. She's 100% different in her demeanor and who she is when she comes into the practice. So one simple question and following it up with an action rather than just putting it in the notes and turning a blind eye. So assessing, maybe our patients are walking into our operatory and they're limping today. Maybe a question about, tell me a little bit about your limp. I see you're limping. Well, they're getting a new knee replacement, right? We don't know if we don't ask. And how do we tie this in? Well, once we look in your mouth, it's really important that things are healthy. You're going into surgery. Let's make sure that we do a very thorough assessment today. So they're prepared. We're dripping information about what's to come. Tying in muscle firing. Many of us, not all of us they're not all doing head and neck exams yet, but when we're doing our head and neck exam, why are we palpating muscles? Are we doing it just because it's rote process? And sadly, that's what some of us are doing today. We're going through the motions. But if we're really feeling those muscles and asking ourselves and the patients if they feel what we're feeling, and then let them know what can be a symptom. This can be a symptom of bruxing, grinding. Well, I don't grind my teeth. Well, let's have a closer look when you and I get inside the mouth. Let's look together. So we're bringing them into this process. and preparing them for what we're going to be talking about.
I don't think I've ever put it in that thought, like we're touching the muscles, because I've always looked for nodes on the muscles, so not so much like the muscle.
The firing.
Yes, and I mean you notice it, and of course you're feeling like the side's a little bit bigger than the other. You must be chewing on the side, those kind of things. But when we're feeling down and under here, I've always, I guess, in my mind, been thinking for nodules that aren't mobile.
Pathologies.
Exactly.
Right. We're looking for pathologies, and we are. And if we, again, I like to always think if we just sort of widen our lens a little bit and say, well, what is a pathology? Is a muscle that's firing on the right side a second before it's firing on the left side? To me, that's a pathology. And if we think about these things, it's outside of normal. It's abnormal, right? And so what do we write on our? We write within normal limits. But is it?
We never looked.
But is it, right? So, and bring the patient's hands up to their face, have them touch their cheeks and clench with you, and help them feel what we're feeling. And this is how we bring our patient into their own diagnosis. And I promise you, once we start including them at a level that's understandable for them, I could say your masseter muscle is firing 1 second before your left side, and that could mean you're bruxing, versus, do you feel the difference in the way these muscles are behaving? And once we look in the mouth, let's make sure we're not seeing harm that's being caused from this. So these are words that patients would understand and use. And we always say use people speak, but even we have a hard time. People speaking. Michelle, you said earlier something about was it data dump or?
Oh, they're not information receptacles.
Yes, our patients are not information receptacles. Yes. Yes, so dripping the information in steadily and gently and lovingly. And we talked about earlier letting the patient know that this is not your fault. When you point these things out to them and they're thinking, well, here I am in the dental practice again. I'm going to get that care credit application put in front of me, and this beautiful new office and that beautiful car in the parking lot. And that's why it's so important to have the team managing this for our doctors. There's so many reasons why, but
I'm itching to interrupt and say that I've never had a hygiene exam where somebody palpated my muscles.
Into your neck and everything? No?
Is that right?
So is this standard of care, or is this
excellence of care?
Excellence of care, because I don't know that.
Well, a head and neck exam is standard of care. We recommend bumping it up because we certainly can feel for nodes and pathology, and we should be, and we ought to be, and we must. And there are so many other things that while we have our hands on that patient's face and head and neck, that we could be evaluating. Structure of the bone while we're palpating along the mandible. What is that feeling like? Are we seeing signs of atrophy in the bone?
Or hypertrophy.
Things that we just don't think to, but we're there already. It takes a fifth of a second to just put your thumb in one extra place. So if we're tying in the health history and then slowly working through the outside, eventually we're going to get inside the mouth. And if we're dripping information, then we're doing a couple of things. We're bringing them into it. And I always like to say we're also handling some pushback before it occurs, which is the best time to do it. So if we can get our patients involved, answer questions for them that we know are probably coming down the pipe. A great one is periodontal disease. When you've gone through all of the motions and gathered all of that wonderful data, and you say you've got moderate periodontal disease, what's the first thing they say? Nothing hurts.
Oh, yeah.
Nothing hurts, and people equate pain to pathology, so if nothing hurts. So I want to share a tip with our listeners on blood pressure. When we're taking our blood pressure, a way to handle pushback before it occurs is say, like periodontal disease, blood pressure doesn't hurt either. And the only way for us to know if it's present is to assess when you come in using this tool.
We're planting the seed for that.
So
What do you say to people who say, I will talk about my medical issues with my doctor, I'm just here for my teeth.
You know, that's becoming fewer, and that's a great sign, isn't it?
Yeah.
If you think of it, because we dealt with that a lot, but I'm not dealing with that as much as I once did. But what do we say is we just give them the why. Give them the why. I'm a touchy-feely person with patients when I'm seeing them. I always suggest that anyone that we're working with, just, put your hand on their arm and say, this is going to help us partner with you to provide excellent care for you. The most important thing for us to do is keep you out of this dental chair as you move through the years. And statements like this, it's not your fault, keep you out of the chair, spending endless hours and dollars, is really something that speaks to people.
And I have also been, and this may or may not, I'm very much learning motivational interviewing. Like, I'm probably screwing it up more than I'm actually being proficient at it. But my moments with patients like that, I have always said, now I'm trying to learn to say, are you asking that question because you believe that the teeth are not connected the rest of it? Like, trying to get them to give me more as a why instead of answering it directly. And I'm still working out my verbiage for that scenario, because it doesn't happen a lot. You're right, it has decreased. I feel like it has, but it still happens. Or even just comments in passing of like, I know you're always asking about my blood pressure, I'm at the dentist, or something. Yeah. It's not a pushback, but it's a little dig almost in a way. So I'm trying to always circle it back around, like, so why do you think that that's not a big deal for us? Or why do you think that that's not something I should be concerned about? And hoping that they're going to give me more so I can engage in that conversation. So
you can answer the real
question behind
which
it.
Is not really
exactly.
Which is so funny, because I feel like all three of us have all very different approaches to that same issue that may or may not be a real issue. I mean, it's so minor. It doesn't really happen very much. For me, I'm more, I guess, more like analytical, and I assume that they just want to know the science, and I talk about the kind of oral systemic link and the links to our cardiovascular system, the things that I'm doing that can have an effect on that, and I can narrow it down to a quick 30-second explanation. But again, I'm only assuming that's what they're really asking, not really diving in deeper and like Michelle does. So
interesting.
But that's something new for me. Like, that's not the way I've practiced for, the last 12, 13 years. This is something that I've it happened one time where I got a good response and I was like, oh, this is kind of nice. And then I've kind of continued to grow. And then we've had a few people on the podcast for motivational interview, and I've been taking more courses, and I have lots of textbooks that I've been trying to read but it is one of the hardest things that I've had to learn as a clinician, was to, I think, without on my own. I wish there was somebody sitting in the corner and be like, but that could have been like this, that when they said this word, you should have said this. Yeah. But now I'm just trial and erroring it with patients when I see them once a week. So I'm not even in practice enough to get that routine down.
Well, it's one thing I'm learning from you guys, because I feel like I'm an advice monster, and I jump right in to solve the problem and give the advice on how to fix. And I did read a study that said the average length of time it takes a healthcare practitioner to jump in when a patient is sharing their health issues with us is 18 seconds. That's how much time we give them before we want to get in there and fix.
Yeah. It's the pause. It's the power of the pause. The other thing that I feel we all can learn from this, and it's a quote that's been around forever. It's, tell me and I'll forget. Show me I might remember. Involve me, I'll never forget. And so don't be afraid to involve your patients. Pick up their hands, put their hands, show them the back of your throat, show them the back of theirs. Let them touch parts of your body that feel normal when theirs feel abnormal. Get them involved. It's just like we often say, sometimes it's like guiding children through the office from start to finish, but think about a classroom. The children that are actively involved are learning. The ones that are sitting in the corner are not. And we know that. So bring them into the mix. Intraoral cameras, I hope everybody has one of those on their tray at this point in time, but prepare them for what we're going to talk about. And if we talk about blood pressure and let them know there are so many, like Andrew, you said that very well, there's so many conditions in our body that are connected to this. So
I want to interject here with blood pressure. The standard of care for managing blood pressure is if a patient is on 2 or more meds, they need to go for a sleep study.
Oh.
So that could be an easy way to get in there. I notice you're on 2 or more meds. Have you had your sleep study already? I just think to myself, as you're talking, I'm thinking, what world do I live in that I've never had a blood pressure taken at a dental's office? I've never had a muscle palpation done. I'm like thinking, is this an American thing or what is this?
No, I think that's just an excellence of care. Like, the practices that Cyndee's probably working with, and we tried to incorporate.
And in fact, I never even fully complete my health history forms for the dentist. I do now, but I never did because part of me is like, why are they asking me all this medical stuff?
So what did she just say? Why?
Why?
If Julia understood the why, she would be filling out the form, and that's where we skip a beat. Go back and listen to Simon start with why and listen to it over. I think I've listened to that hundreds and hundreds of times, and each time I pull some little nugget out of it. That's one of my many favorites.
Simon Sinek, if anybody is curious about that.
Yeah, I love him. I tried to give him a hug at Serona, but the line was too long. He said anything, and I thought, well, that qualifies for anything.
She's like this, marry me.
He's my hero business-wise.
Yeah.
Sure.
Yes.
I love the way he thinks. So then once we move into the mouth, being aware of what to look for. So Julia's gone through a litany of things today that we can look for, and at the end of this, we're hoping to give you some simple tips to just pop into.
Cookie cutter
things that you can just plug and play. But looking at the airway and being able to ask questions, one of the things that we all could be better at doing is giving our patients the grace of asking a question if they have it. I think dental people and medical people are so amazingly brilliant that we dump everything we know on them.
Can I ask a question about that? I feel like there has to be a better way to get that, or to give them the opportunity other than, any questions? Because that's what we do. It's
Absolutely.
Blah, blah, blah. I told you 1,000 things. Any questions? No? Great. Let's move on.
Yeah. Any changes? Great.
No.
Any questions? Great. Any complaints? No. So let's talk a little bit about open-ended questions, right? And we do that because we've been programmed. We walk through those doors and we hop on that wheel and we go all day full tilt until the day ends. And then we go, oh, crud, I forgot this and that and this and that. Open-ended questions or question-based interviewing. And if you have somebody that's just you're still not getting what you need, tell me more about how you do this. Share with me a bit more about how you do this, how you feel about this. Kind of pull it out of them a little bit. Because I'm going to take the closed-end question answer any day of the week if I'm given that one, because it's all about efficiency. I want to share with you, speaking of that, we did a study, a poll. We took a poll of over 3,000 patients leaving dental practices, and they want 3 things, and one of the 3 was efficiency. So when you take the time to ask patients what they want, deliver it. And so if they want efficiency, find a way to succinctly deliver the information and then ask a question. Let them ask us the question. So once we go into the mouth, the Malampati, are any of you using the Malampati for your work? Go online and download it. You can find it all over. Just type in Malampati and images, and you'll get a great little image of what that looks like.
It's like 1 through 4.
Yeah,
right?
and we can even give you one, and you can put it on your site if people want to download it from your whatever works best for you. But those are simple ways to assess the airway. Is it all the way open? Can you see to China, or you're able to see is a big tongue in there? and then talk about that. I won't belabor all of the things that we talked about in terms of physiology and the way that the body's behaving, but being able to recognize the very basic scalloped tongue, linea alba, wear, abfractions, muscles that are firing unevenly, and then help your patient understand that you want to show them the harm that's being caused as a result. And we talked earlier about night guards and anterior wear. When your patients say to you, I never put my teeth in that position, to say, I bet you never know that you're doing that, and here's why. Show them the airway, show them yours, give them a mirror. Julia, do you want to add anything about neck circumference? We talked about that. There are some offices that are measuring necks.
Yeah, I mean,
how do you feel about that as a patient?
I'm like, I thought I came to the dentist, not the tailor.
I think using that as a way to broach the subject is going to meet with a lot of resistance. Basically, you're saying, I think you have a fat neck, and without addressing the why first, I think that's way further down the line, where you talk about how you can get a buildup of fluid from the inflammation in the tissue. It's not always related to weight, but the patient's going to hear it as a weight thing. Hypothyroid, for example, is strongly correlated with OSA because both accumulate fluid in the submandibular tissue.
And we're finding that a lot in dentistry, a lot of enlarged thyroids. That's another easy assessment.
Let me put it back to you, since you're the communication expert.
Am I?
Let's say you did have to get that information, because when you're doing certain home sleep testing, you have to put in, what is the measurement? Is it over 17 for male, over 15 for women? So how would you go to that patient and say, I'm going to measure your neck?
So we wouldn't. And as you said earlier, that's further down the line. The most critical piece of this is just introducing something that's going to be new to most patients. Although we've had a patient who, when we've asked that question, they said, yeah, I'm wearing a sleep appliance. Well, where is it? Who's doing it for you? All these questions start going through your mind. And their chiropractor did the assessment and referral. And if that doesn't sort of widen your eyes and things that make you go, right? So here's your patient sitting in your chair that's been treated by somebody a little more comprehensively. That's
what's interesting about that is the dentist who made the oral appliance for him. This is, again, communication. Why would you not communicate with the patient's dental office to let him know? Was there communication with the patient's family physician so that they know? So this is where we can really start to close some loops and create a referral source, and it goes beyond,
Now, the interesting thing, too, about that, and I want to come back to the assessment, but creating a referral source, that's part of what we talk about here. That's one of the biggest challenges, is having that channel open. On that note, we did make a phone call to the chiropractor to say, wow, great care, thank you. Do you think we could get through?
No.
We couldn't get through. And we said, can you just give us a call back? We'd like to speak to them about a patient. Didn't get it. So there are barriers just to finding a referral circle. So that's one of the first points that you need to fly.
Do you think that was just because they were busy, or they just mitigate the importance of the dentist, or like, I wonder what the why was behind not returning that call? And then, did the patient know that the chiropractor? Because that's always my next thing. I was like, I tried to talk to him. And so maybe now you can go and deal with that, because I can't get anywhere. But I don't even know if that's fair, if I'm kind of undermining that chiropractor office or whatever office.
That's interesting, because the information that we needed was really benign. We wanted to thank them for that comprehensive level of care. So it was an interesting, just another reminder of how fragmented this is, how fragmented it is. On that referral note, one of the tips that we can share with you is those referral slips that go back and forth, that are printed or that go online, we have complete control over how those behave, what they say, and what the relationship between you and your referring specialist may look like. So it's not unheard of that when you have that relationship to go and say, hey, any patient that comes from our practice, this is what we do, this is why we're doing it, and this is how we'd like the referral process to go with you. And they're very open to that. I've yet to find a specialist that wouldn't change their system slightly to accommodate a more comprehensive level of care. So, Michelle, if somebody were to ask you, has anybody spoken to you about your airway? Sounds to me, based upon the other episodes, that you would have a lot to share with us.
As for me personally?
Yeah, just based upon you had said that you wear a night guard and that you've, sometimes you're breathing, you have struggle breathing. So would that be an intrusive question?
For me, not really, but I think even knowing the things that I know, like the malimpedes, like you can see to China down my tonsils aren't enlarged and all those things, but then if you started to like delve into, is your mouth dry at night, or are you wearing a night guard, things like that. I guess my problem, I can't get past the night guard and how that's where I struggle with the physiology of how that is a sign of my airway issues. But that's also coming from someone that's worn a night guard since I was 16 years old. So like I think that would be my conundrum, is how do I let go of that? It's not so much the question and action or answers that you're giving me, but now you're taking this thing that I've had for a really long time away from me, and I can't make that connection between the airway and that,
Interesting. So it's just a habit, an established habit. Boy, are we talking
and
about
like a
that
comfort, and a level of comfort for me, I think, too.
And so what I would say with Michelle is there was a missed opportunity somewhere along the line because you're tongue-tied. And nobody has explained to you that the bulk of your tongue is tethered in the back of your throat. So some of the other signs that we might look for may not be present in you. But when you're talking, we can see the dysfunction with your tongue. So your brain compensating and creating the wear, and they put a mouth guard in to protect your teeth, and it has, the underlying issue is still there. So it will manifest itself in other ways.
Very interesting, isn't it? So going through with the assessment, so the next step in the assessment would be we would go to radiographs. The next thing would be taking their checkup films. And if we have a patient who struggles to lean back or gags when we're taking those radiographs, historically, and what we still hear today is, here comes, we'll call her Mary. Here comes Mary again. She's a big PIA. She doesn't want to have the x-rays, probably because she doesn't want to pay for them. And so we start embodying Mary with all of these quirks, when in fact, if we were to consider looking at the back of the mouth on a patient who's gagging during radiographs, what might we find? And to be able to think outside of that box and really step outside of ourselves when we're working with our patients. The other thing is the patient that can't lean back. We make fun of those patients in our practice. Oh, they're the pain. What does she sleep upright? Does she never go into a bed? When in fact, as soon as we start to tip those patients back, they struggle with their airway. So we have this perfect opportunity. They're giving us a symptom. They're saying, I don't like this. And we can give them the because, the why, right then and there. Set them up. This is not your fault. Those words are so powerful in a profession where patients are so used to being what? Lectured. Right? I'm getting another lecture. So I'm going to jump from the assessment for just a moment and talk about education and hygiene. Julia and I have talked about this ad infinitum because nurses have always paid for their own education.
And so I think that there's a dynamic there. Nurses went through a transition period probably, I want to say about 20 years ago, where we were really trying to define and elevate the role of nurses in the medical industry. and not be viewed as a doctor assistant or and really take on the role that our license allows us to, which is to be an independent, autonomous practitioner. So to do that, we took charge of our own learning path. And so depending on which area you work in, so for example, I work in the emergency room, so I would take whatever certificates and courses I need to take and keep up so that I can be a proficient provider. And then the doctors know they can expect a certain level of care from me, and you build trust between the two. So the communication changes when you have that level of trust. And in fact, some of the courses we take together. So that, for example, ACLS, doctors and nurses will take it together. So when you're in a code situation, we're using the same language. They know what I know. We're all on the same rhythm, and everything flows. And so when we started working together, what I noticed was that it seemed to me you only ever saw hygienists at a course that the doctor they worked for decides to pay for them to attend. And in many cases, conference after conference after conference, the doctors are there taking the courses, the hygienists are not, or the team is not, let's say the team. And then the doctors are complaining they're not getting the success they want.
Yeah.
They're saying, my team's not on board. I go back and I take it to them and they resist me. And there's a disconnect there.
Well, the dynamic is certainly there, and it's alive and well.
Kicking.
Alive and kicking,
Fiercely.
not well, yeah. The dynamic is absolutely there, and there's some factors that are very interesting. One, if a doctor decides to take the team, they typically take the team members who are paid the lowest wage.
Okay.
And so hygienists typically get left out of that because of that. The other thing is there's one doctor, maybe two, maybe three in a group practice or a small group, and then for every doctor, there are how many team members? So what you just spoke about is calibration, and that's we spend the majority of our time in the early stages of training on calibration because it doesn't exist in our practices. And so if doctor's saying one thing or implementing something and the team has no idea, there's a fail. Hence Airway, hence Perio, many of those things. So when it's not paid for, many of us seek the least costly way to get our units. They go online and take whatever they can buy for the $100 to get the 25 units. And that's not the level of education that creates a high-level performing team. So Airway is one of those. Perio is one. Laser is one of them. All of these things that have added themselves to our list of responsibilities and raised the level of care for our patients, we're not seeking the education for. So,
but I also think, if I can interject,
sure.
I also think that the industry itself has perpetuated this cycle of continuing education at a cost that they know the dentist will pay, and staff has been added on, discount for staff. So it doesn't translate well, though, to take that amount and then say, okay, if you're a hygienist and you're going to take your own learning pathway, here's what it's going to cost you, because it's not fair to the hygienist. One of the things I feel passionately about is creating that quality education at a cost point that hygienists can take on. So that means drastically reduced price. That's only fair. So that will be coming. We're all collaborating on that. And I think I want the listeners to know we get it. We understand what the issues are. It's one thing to say it, but there has to be something to follow up with, right, to provide that education. And just because it's less expensive doesn't mean it's not quality.
Right.
As long as it's evidence-based.
And just because it's expensive doesn't mean that it's quality.
Exactly.
So what Julia speaks to is very valid, and I think we all at this table agree with that.
Yeah.
But that's for people in a profession of hundreds of thousands.
True.
And if we don't educate ourselves, then we end up practicing at a level that's not at standard of care. So being an advocate for ourselves and being an advocate for the patient. If we're not an advocate for ourselves and really raising the level of education that we take, How can we be a good advocate for our patient? And again, I go back to it's not your fault if you don't know what you don't know. But at this point in time, it's time for all of us to recognize the life-threatening and life-altering conditions that we work with in dentistry and take the steps to get yourself educated so that you can be an advocate for your patient. We all like to say, practice as though the treatment is free. It's your mom, it's your dad, it's your brother. But you still have to have the education to know how to treat your mom and your brother and your friend. So I'm looking forward to hearing more about the courses and what that's going to provide for dental hygienists and dental teams. I feel like I'm the only one talking here.
Well, this is your forte.
Yeah, I know.
Yeah, I felt like that for some of the other ones too. I was like,
So one of the biggest things that we tend to do is give too much information. I touched on that a bit ago. When you go back to your offices and you go back into your next office meeting, sit down together and ask yourself a question. Pick a procedure, whatever that is, a new patient assessment, and say, these are the things we're going to cover. Let's sit down in the room and present that to a patient and hear yourselves say it. And you'll quickly learn that you can trim about 2/3 of that away. And so go back, present the treatment to your patient, present the issue, the subject, whatever it is, and trim it down to a succinct people speak version. Ask yourselves, if I were a patient, how many patients point to their bicuspid and say, I've got something stuck on my molar? Right?
Yeah.
So we think we can say molar and a patient will know, and they don't necessarily know our language and what that means. So trim the fat, present the treatment to each other, and that's the opportunity for the missing calibration too that you talked about earlier. People speak. I want to talk about the executive summary. When you're giving the assessment to your patient, give the executive summary and then let them ask for detail and fill in those bits. Andrew, you asked a question earlier about giving information and getting a question back. There's more to it than that, and that is, what's the information that's being delivered? So are we giving them a succinct version of a rich procedure or process or assessment, or are we just giving them a drip of it? Well, you've got some wear. That's very succinct, but what does it mean? Is anything hurting? That's very succinct, but what does that mean and what will we get from that? So being able to bring your patient, going back into those assessments, set them up, give them a mirror, bring them, have the picture on the screen, show them the wear, show them the harm, and give them the good news. We all sit in those chairs and watch their shoulders drop as they're being bombarded with information. Give them the good news. And what is the good news?
It's not your fault, and
there's so many things that we can do to help you that are so simple. The sleep studies in the office. Are either of you using the little take-home sleep studies? Is it the finest way to get a sleep study? No, but it's a great screening tool, and it's a gentle way if you want to get some information or just gently introduce your patient to this process, to have that available. Julia, what are you recommending for your offices?
I don't know that I can add much more to what you're saying in terms of the questions and the assessments. I do think not overwhelming is a challenge. What I see is providers, we get excited about what we're learning. I'm so guilty of it, just so you know. We have so much information, we're seeing so much, and we want to tell them everything. And what I see is the look that flashes across their face when I realize I've gone too far, said too much, and I've lost them. And I wish I could dial it back to the place where they were intrigued.
Yes.
So that is something I struggle with, and I have such an earnest desire to help them, and I know we have so many things that can help them that I just want to convince them.
So I have a couple of things to speak regarding that. One of them is asking their permission to share with them what you're seeing. So once you've been given permission, then you can go ahead and move forward. So asking, Julia, is it okay if I share with you what I'm seeing? And once they say yes, go into that. I spoke about the 80-20 earlier. I think I just touched on that. In hygiene, many of us are limited to an hour time. And we're doing these comprehensive assessments. We're periodontal probing and charting recession and furcation and mobility and talking about caries management and talking about perio and talking about restorations and talking about health. One of the things that I think we can all really become better at doing is forecasting. And forecasting is not only part of the treatment planning, but it's about how much time do I have? Where does the highest level of value lie within that time? When will I see this patient again? And is it absolutely imperative that I cover this today, or can I cover that and pick that back up when I see them maybe back for their periodontal therapy or back for the restorations with doctor? And that really removes sort of what I call the dog's breakfast, where we're scraping everything in the fridge onto the plate and handing it to the patient, and they're going, well, what do I do with this, right? And so they leave and they do nothing. So if we can ask ourselves, okay, the first thing is pain. Are they in pain? We want to address that. Then what's the most do they have an active infection? And what do they have that's life-threatening? What is a serious health risk that we're facing? And then how can we tie those 2 or 3 things together to keep it simple, but not negating the fact that we have a litany of other things to discuss. But to say to Julia, there's a lot going on. What I'm seeing as most important right now is that you feel better, and that we really, really address some of the things that might be causing your weight gain or your tiredness, your lethargy, your blood pressure, whatever those things are. And I'm going to partner with you, and we're going to work on this together. Okay, we're going to hook arms and work on this together.
That's a lot different than saying, I see all sorts of signs and symptoms of airway issue and sleep apnea. So you need to go talk to your doctor about it, or go get a sleep test.
You go fix yourself.
You go.
You'll get it fixed.
Yeah.
Right.
Yeah.
Interesting.
Yep. So becoming a partner with your patient and your doctor, and really learning the delicate balance with time management. We all struggle with that, but if we take the term time management and we change it to patient care, what's the most important here? And when will I see them back? It's not the end of the world if we don't disclose and show them how to brush their teeth. If they're going to get set up for a sleep study today, we only have an hour. Right. We'll do that next time.
You
and
can
it's
choose
okay.
your battles in that.
Yeah. That's a valid point. We give them way too much information. And what did they ask us for? Efficiency. They asked us for efficiency. We asked them, what do you want? They said efficiency.
Yeah, white.
Yeah, exactly.
A glass of wine. I want a glass of wine. That's what I want. So we won't even dive into how to address people who are insurance driven. I just want to touch on that slightly, because that's one of the overwhelms that comes along with integrating sleep into a dental practice. And that is, how are we going to be paid to do it? And so then we take one of 2 paths. We go and we fast and furiously earn a way that we can generate income doing it, or we do nothing. And neither of those are necessarily the best way to go about it. So balance, finding a good happy medium, finding a comprehensive care-based solution to implementing sleep into your practice.
And I think one of the things we have discussed is say what you see.
Yeah.
So at the beginning, I think the implementation of sleep into any practice, medical or dental, it kind of starts in baby steps. If you can at least have a few things to screen for and say what you see and to raise the topic with your patient. And even if at the beginning, when they're asking for treatment, you refer, so you screen and refer, that is a success. I think some practices, and what I've heard from some providers, is they've tried to implement the whole thing, including the medical and dental billing and the treatment and the titration, and they've done, and then have fallen flat and given up and said, I tried and I can't, and they stop. That's not the answer either. I think start and become successful with each step of the way. Build your confidence, build your knowledge, and
Absolutely. And be consistent. Even if your consistency is just screening and referring, be consistent. One of the things that is most important, if we see it, say it, and document it, put it in your treatment plan, come up with something that you call sleep referral, and create a code and get it in your system so that you can put that in your treatment plan for 2 reasons. One, if it's important enough for us to talk about it, it's part of the treatment. And if we talk about it and we give it any energy, and then next time we see our patient and that doesn't come up on our router, or we don't have a thorough morning meeting and we don't know we talked about it and we didn't read through the 6 pages of notes, what happens to that in the eyes of our patient? So that procedure, that process, that issue, that seems to be our word.
And can we go back to the 60,000 foot thing?
Yes.
Because what that does, even if we didn't initiate the treatment of that, but we have a patient who came in and identified that they are on a CPAP or they have a sleep apnea appliance or whatever, if we don't follow up to see how they're doing and check with compliance, that's a huge issue. And we know the epidemic right now is because there's lack of continuity of care. CPAPs are being handed out like candy. And even the sleep doctors say they're just as guilty of being happy that they gave the CPAP, but the compliance is lacking and that follow-up. So part of all of this, included in these podcasts, is to make sure providers of every sort are helping with the continued support and encouragement that our patients need to follow through on treatment. Because of all the reasons that...
Well, why are we there? To get our patient from the dental chair, from the exam, onto the schedule. What is that telling us? It's telling us that we're looking after them, they're receiving the care they need and deserve, and they are on a path for good health. That's why we do what we do. And if we're human. You know, we don't remember 16 patients from last month, but if we have a system in place where it's automatically coming up for us to see. And the other thing is we may want to check in on our patients. How easy is it to run a report of all the code, ABC, and be able to shoot an email to them? How are you doing? Can we support you in any way? Have you had the sleep study? We have a great new resource for you. It's a metric that we can actually utilize to benefit those patients when they're not in our practice, when they're not in our chair. And that's, we see them, 4 or 5 times a year. There are still 361 days in that year. So if we talk about it, put it in the treatment plan.
I love the follow-up because I wish I had more time in my hour or more of an hour for the follow-up. I wish I could type notes for my patient to take home with them, to have like that physical copy. I wish there was like text messaging and emailing that's like, hey, Mr. Jones, I'm like, the sleep, just want to follow up with you. This was a concern of mine. I'm excited to discuss it with you at the next appointment or whatever that looks like, because I need that. Like, there's a lot of times where I get text messages, I'm like, oh, yeah, we did. Or my vet gives me
I was just thinking
the most detailed
Yeah.
information. They follow up with an email afterward. How is Lola's
I get phone
doing?
calls.
Yes.
Just checking to see how Roxy's doing.
Yes. And I'm like, why can't I do that for my patient? I want to have that conversation. And not just for them, but also for me, because that will put that in my memory bank a little bit more.
Yes.
If I can have that engagement.
To speak to that too, we talked about being healthcare professionals, and there are so many of us in the profession who have this mindset that they clock in at 8 and clock out at 5. And as a healthcare professional, we're treating patients during those hours. And so these follow-ups, to take a copy of your patient list and their phone numbers. We're all in our car. Most of us are in our car heading home at the end of the day. That's when I make my post-op calls. I'll just dial my patient right from my car and check in on them. You want to improve the patient experience, you've done that. And also, you have notes and documents now that you can follow through with. The other thing is, Michelle, I think you should invent that.
Add that to my list.
Yeah, I think that'd be very useful.
I would love that, but I think it also comes with the time, and we could probably get into the time with the next episode and talk about those troubleshooting issues. But I think that's always going to be the case, and not just because I'm in a practice now that I could be given the time, but then I have my life to live afterwards. So it's like, you give me the time, but I'm still like, I might not have it that day, even just for practicing and seeing patients. But, it's always that conundrum that we're coming
It is a
across.
huge conundrum. We don't have someone in taking our notes and doing all those things.
Maybe Andrew does.
Oh, well.
Anyway, I touched the sore spot there.
No, I
I like
mean, she rubs it in all the time. I do have an assistant that helps me do
Yeah.
just about all of my paperwork.
Yeah.
Yeah,
And
I do like to rub that
post-op
in.
calls we put on the schedule, and they can make those calls for us.
very nice.
And we have, we call them care advocates, but it's basically your people that work in the front office are given trainings to be able to make those post-op calls too with some
Love it.
background training.
Awesome.
Love it. I think we need more care advocates in dentistry. That's wonderful, Andrew. Wow.
Yeah. So anything else before we kind of surmise this and let it soak in for a week until we hear this next one?
Yes, I think we're out of time. They can go online and get the Malampati. They can get the classifications of tonsils just for a visual to see what they're looking for and how to assess, and then talk about it and make a referral, even if it's back to their medical doctor, even if it's just to the physician.
Excellent advice. And so next week, we're tackling kind of the troubleshooting. Maybe?
Yeah.
Like some tips and tricks, little nuggets that you can take back and just like Monday morning start seeing patients and you see that one thing and you're like, oh, but I know what to do now. So
Just a couple of quickies, questions, things you can observe.
And where can people find you to ask any specific questions or follow up?
Cyndee at scalartoschedule.com.
And Julia.worrall at airwayhealth.org.
Awesome. You guys are amazing.
Thank you, guys.
I hope that you feel like each week you are learning and it's compounding on itself, because that's really how Cyndee and Julia designed this. And you heard us say at the very beginning, like, we're really starting to see it. Like, the more we delve into this, we can't unsee this in our patients. But then what? And I hope you feel like you got some answers from that today.
I feel like we're just very fortunate that we have these two clinicians kind of taking us by the hand, just like leading us through this little bit. But at the same time, I know that there's going to be plenty of you that have questions still about it. You can't hear everything on a podcast that you need to know about Airway. Make sure you're checking out courses and things like that. Contact Cyndee and Julia and ask them where the best source of information is for a lot of this. And we'll continue to bring you things as much as we can, but they really are the experts. So please reach out to them, and their email addresses, while they said them on the interview portion, is also in the show notes. So don't forget about that.
Like you just said, attend a course. And it's so funny because as we were about to record this, we got an email from one of our listeners, Lisa, who has emailed us before. We've met her at Greater New York. She's so fantastic. And she got an email that had the Airway course information on there. And she's like, I'm going to it. And you should do the same. Like, go seek these courses by Julia, by Cyndee, because you won't regret it. This is just scratching the surface. To hear it and learn it in person is going to be amazing. Hopefully this just piqued your interest. And like I always say, taught you just enough to be dangerous with your diagnosis. And then you go and you really delve into it a little bit more.
Yeah, I couldn't agree more.
So if you want to send us messages like Lisa did, you are welcome to do so at ataleoftwohygienist@gmail.com. And you can also check us out at ataleoftwohygienist.com. We would love for you to go there and subscribe. We plan on doing really fabulous things. We have some people that are going to help us, and we got really great plans. So go sign up, subscribe to our newsletter. If you want to, please engage with us on Facebook and Instagram. We love it. Love it. I just got done saying how much I love our Instagram account. So send us direct messages, like, share, please share, and also tell these guests how awesome they are and what their knowledge and expertise taught you, because they really do appreciate that, guys. Anything else, Andrew?
No, I think that's it. Have a great week, everyone.
Yeah. Bye, y'all.